12 years ago, a 55-year-old Chinese gentleman by the name of Mr. Lim, not his real name, of course, presented to our boys at ER with a massive acute myocardial infarction in the wee hours of the morning at 2. Some 2 hours earlier, he had sudden onset severe central chest pain at 12 midnight. When he was seen at ER, the severity and extent of his infarct was judged to be massive by the look of the changes in the 12-lead ECG. An anterior infarction, my medical officer rang me, the type of which was actually touch and go situation, whereby in this kind of situation with the massive types of anterior myocardial infarct, even the in-hospital mortality is considered significant or was considered significant. He was duly wheeled direct from ER to the cath lab, where the emergency team was waiting for him within half an hour of his arrival at the ER. A fairly good door to balloon time, considering that it was 2 a.m. in the morning. It was an anterior myocardial infarct indeed, as the left coronary angiogram showed. His left anterior descending artery was totally occluded, just millimeters away from the Widowmaker's junction, that is the left main stem. I crossed the blockage as usual with a guide wire and do several rounds of aspiration of blood clots and debris using an aspiration catheter called export catheter. Then after that, duly deployed a balloon and then successfully stand the lesion with a long stand. The left anterior descending was totally open after those procedures. His recovery in the CCU in the next 3 days were quite stormy, given the size of the infarct in view of the amount of myocardial muscle involved in the blockade. Despite quite heroic measures that we take earlier on, 1 month in the outpatient echocardiogram shows a very much reduced left ventricular ejection fraction, which is expected since he lost large amount of viable myocardium in the initial onslaught of the acute myocardial infarct. The echocardiogram showed a left ventricular ejection fraction of about 20 to 23%, despite now having a fully patent left anterior descending artery. The normal contracting heart would be about a left ejection fraction of about 55 to 80%. He obviously has a failure problem. So he was put on the whole gamut of anti-failure armamentarium of diuretics, low-dose beta blocker, and ACE inhibitor. ACE inhibitor being the mainstay of this standard triple regime for treatment of heart failure in those days, and even currently. In the follow-up, years later, he had rhythm problem related to all biggish heart related to heart failure, with the onsets of fast atrial fibrillation alternating with atrial flutter. After a trial of an expensive radiofrequency ablation treatment by a younger colleague of mine specializing in electrophysiology, and we call them the electrical boys, at 6 years post-infarct, it did not seem to work better. That was the early days of radiofrequency ablation, when equipment was rather still not sophisticated. At present, the results of radiofrequency ablation in cases of atrial fibrillation has tremendously improved. His left ventricular ejection fraction over the years was hovering between 25 to 30. Then came the new wonder drug for heart failure, the Entresto, replacing the ACE inhibitor as the mainstay of treatment. And I put him on a new armamentarium. I've been waiting for this drug for the last 36 years. After 6 months of usage, a repeated echo shows a whooping left ventricular ejection fraction of improved from 25 to 45%. So for this one rat experiment, it shows tremendous success. Mr. Lim now is more active than before. In the last clinic follow-up, he asked me, "Dr. Nick, how long do you think I can last?" I looked at him long and hard and I said, "Mr. Lim, when I saw you 12 years ago, I thought that it would be impossible for you to celebrate your 60th birthday. Now you are 68. I think if you don't go around chasing young girls and stop smoking and your hard drinking, you may even last longer than your doctor." I told him half jokingly. We both had a good laugh after that. As I look back at 36 years of cardiology behind me, I can only say that myself and the whole cardiological communities across the globe are a very blessed lot. Firstly, we have the whole gamut of the pharmaceutical industry behind us to come up with new drugs all the time, better and stronger, not necessarily translated as cheaper, unfortunately. But even though the progress in the pharmaceutical industry is dollar-driven, the upshot is that we have better and better lipid-lowering drugs, new anti-failure drugs like Entresto, with old hands like me waiting for the last 30 over years for new drugs. And now, even more effective anti-diabetic medication. And by the way, I see diabetes as not an endocrine problem, but almost 90% cardiovascular. That it is now a very cardiological issue rather than an endocrine issue. Secondly, we have industry-driven devices people who come up with new and effective and easy to deploy stents and balloon, heart valves, and in the EP fields, new equipment to burn out iron pathways and circuits in the heart. The only thing we have not yet seen is that there is no significant movement in the stem cell research department. There so far has been no positive results in this field. When it does, I want to be there to be able to play around with the new toys. Subhanallah, walhamdulillah, wa la ilaha illallah, wallahu akbar, wa la hawla wa la quwwata illa billahi al-aliyyil azim, wa la hawla wa la quwwata illa billahi al-aliyyil azim, wa la hawla wa la quwwata illa billahi al-aliyyil azim.